Let's talk about getting patients to do their homework. That involves educating the patient about their condition and how to be proactive about their treatment or therapy. You'll hear the words compliance or adherence a lot. Those words simply mean using it or sticking to it. If someone is using CPAP well and doing it every night, that patient is adhering to treatment or they are compliant with their therapy. Think about the word adherence. It looks a lot and sounds a lot like adhesive, sticking to it. Not too many years ago, doctors would see a patient and just decide what course of action to take, and the patient was expected to follow that treatment, no questions asked. This violates two areas of healthcare integrity: patient education as well as patient consent. With the patient's Bill of Rights, the patient has a voice in their care and has access to all their health records. Patients can deny treatment or therapy. That's where the education comes in. The idea is if we can convince the patient they need a medication or therapy to live or simply live more comfortably by telling them all the scientific proof we have on it, they are more likely to adhere. There are a lot of different things to think about when speaking to an audience, let alone trying to educate them. Gender, uh, their learning theories or how they learn, age, the materials that might be appropriate for them to learn from, and social determinants of health. Social determinants of health are conditions in the places where people work, live, and learn. And it affects a wide range of health risks and outcomes, and they include healthcare access and quality, how easy it is for you to get help if you're sick or injured, education access and quality, how easy is it for you to go to school and get a good education from good teachers, social and community context, where does the patient fit into their community, economic stability, how easy would it be for the patient to pay for things and live comfortably, and their neighborhood and built environment. How safe does the patient feel in their home and with the people that live around them? Patient adherence to physician orders or recommendations can be complicated. Not only are there a myriad of medications and treatments available to be considered, but also the cost of therapy, the side effects or difficulty in using therapy, health literacy, or how well the patient understands what's medically going on with them and what we can try to do to help them. Language barriers. Do we speak the same language? Age. Does the uh, adherence for therapy increase or decrease depending on age? Does the efficacy of therapy increase or decrease with age? Is there a cutoff age where therapy should be terminated? Is the patient old enough to use therapy? You go both ways, young and old. And access to care. Will the patient be able to come to appointments and do what is necessary for the therapy to be administered properly? Trying to predict whether someone will adhere to therapy is difficult. Not everyone fits into the cookie cutter one size fits all category in therapy. At the same time, trying to shape therapy around each person may take more time than one approach. For example, they may require different teaching techniques if they have a learning disability, for example, and community resources. I'm originally from Selma, North Carolina. That's right next to Smithfield, where Johnston Memorial Hospital is. And they have a sign out front that advertises free classes for diabetic support, cardiac health, and nutrition. That's an example of a community resource. Um, Support groups, churches or community centers that raise money for awareness or research all fall under community resources. When the patient does not adhere, everyone loses. This is wasted money and an unsatisfactory outcome that leads to a poor quality of life. I can't tell you how many times I've met someone who's sworn off ever going to a sleep lab again because of the horrible accommodations or staff or treatment they experienced. We're talking about taking care of people at their most vulnerable when they're sleeping. If someone with sleep apnea came to the lab and was treated horribly and their views on sleep medicine were ultimately destroyed, they may never try and fix it, which can just cause all sorts of secondary disorders. Although we may think that patient education starts with the patient and the physician, the clinical sleep educator can also have a positive or negative effect on the patient's overall experience. As healthcare becomes more and more complex, the role of the clinical sleep educator is evolving and expanding. If you have a CCSH, the Certification in Clinical Sleep Health, you can see patients and charge them a fee for sleep coaching sessions, all under the supervision of a physician. You also have the responsibility to help the patient understand the generalities of their issues. You have to be careful not to diagnose or try and prescribe your own treatment, which is beyond our scope of practice. But clinical sleep educators should investigate what patients need a certain kind of therapy and when. Patient-centered goals, which is to provide the right care to the right patient at the right time. Clinical educators are also a vital piece towards improving adherence to sleep treatment. Physicians don't always have the time or tools necessary to help patients that technologists may see much more of. The educator can provide patients with the tools necessary to maintain their treatment at home, which is self-management. Let's expound upon patient-centered care more because there's a lot to it. It's the integration of several aspects of care that have to work together. This includes shared decision making. Does the patient and physician agree, which doesn't always have to be the case, but agreement is easier to get them to adhere. Care coordination. Should other providers be involved in a timely manner? Can they be scheduled for appointments easily? Accessibility. Are they able to understand and physically commit to treatment, or do they require extra assistance? Top-down commitment to ensuring alignment with patient-centered goals. The physicians at the top, we follow the orders and try to supplement with encouraging words or tools. Family inclusion. Would a spouse or parent or child help adherence? Is the patient too young to do the treatment themselves? Is the patient mentally capable, in which they would need a family member to help? Family is big in many cultures and considered consideration of social determinants of health, which we spoke about earlier. Can the patient get to appointments? Can they afford treatment? Uh, Information sharing and the back and forth communication necessary to compel patients to stay healthy. Lots of different things come together for one patient. Everyone takes diagnoses and treatments differently. Some welcome it, others are fearful, and still others are indifferent. Uh, Multiple factors influence the patient's response to treatment, including side effects of the treatment and the impact of the bed partner. This can be true for all modes of treatment. A leaky CPAP mask can wake up a bed partner and be really irritating. Taking Ambien at the wrong time can lead to parasomnias, some of which can be violent against the bed partner. Overall, a patient-centered approach is optimal when compared to a one-size-fits-all attack. Patient-centered care is part of the 6 aims for healthcare improvement. What are the 6 aims of healthcare improvement, you ask? Number 1, safe. Avoid injuries to patients from the care that is intended to help them. This includes all aspects from devices to medications and facility safety. Number 2, effective. Providing services based on scientific knowledge to all who could benefit and refraining from providing services that are likely not to benefit. Uh, Frontal lobe lobotomies come to mind. At first, it seemed that those patients' behaviors were improving because they weren't wild or whatever. The relatives were sent them for the procedure complained of, but after it was shown to be unsuccessful. It wasn't used as much until it was officially banned. It was simply an ineffective treatment. If you don't know about the frontal lobe lobotomies, through the ice pick lobotomies, check it out. Number three, patient-centered, providing care that is respectful of and responsive to individual patient preferences, needs, values, and ensuring that the patient's values guide all clinical decisions. Religion, culture, family, ethnicity, traditions, they can all affect a patient's medical choices and they should be respected. Number four, timely. Long waiting times and harmful delays can be discouraging and potentially life-threatening for those who are receiving care, not to mention maddening for those who are trying to provide care. Number five, efficient. Avoiding waste, including waste of equipment, supplies, ideas, and energy. If there are clear avenues of treatment, they should be followed. Experimental studies or treatments that have a low efficacy takes time away from potentially positive treatment. Number six, equitable, providing care that does not vary in quality because of personal characteristics such as gender, ethnicity, geographic location, and socioeconomic status. A physician should not turn down a patient because they cannot afford their bills, but that happens all the time. Patients are discouraged or patients are discharged for overdue bills. Patients who appear to not make a lot of money should not be paid less attention to. You shouldn't give your mom or dad a better sleep study because they're your parents. You should give everyone the best sleep study you can always. Health is the only thing you really have, so when it's gone, that's it. Shared decision making usually begins and ends with the physician's approval, but the sleep technologist can start the process by providing an educational foundation. In 2012, the first three-step model for shared decision-making was proposed and then revised in 2017. Team talk, option talk, and decision talk. We're always learning new things about health, and technology is always progressing. So we improve ourselves with our own education with programs and activities to accrue CEUs or CECs. Here's more on the three talk method of shared decision making. Team talk includes working together, describing choices, offering support, and asking about goals. Option talk means discussing alternatives using risk communication principles. This makes me think about experimental treatment odds. It's a 50-50 shot. Even something simple like a tonsillectomy still has risks, and alternatives should be discussed. Decision talk is deciding on preferences and making preference-based decisions. There are a couple of concepts to remember when talking to patients in this way. Active listening is paying close attention to what is being said and then repeating their words in your own words to show that you're understanding. Your responses or questions that follow show how much you're paying attention. Deliberation is thinking carefully about options when facing a decision. Consider all the options and what's the best thing for everyone involved. Patient care coordination is the deliberate organization of patient care activities between two or more participants, including the patient, involved in patient care to facilitate the appropriate delivery of healthcare services. Through teamwork, we're trying to make the patient's care as easy and smooth as possible. When the physician is not available, the sleep health educator can serve as an intermediary. This is a model of a care coordination wheel. It's a nice visual on how many different aspects of healthcare have to come together and provide different pieces of the puzzle for a holistic approach. Take note, holistic means whole, not crystals and veganism. In order to meet the patient's needs and preferences in the delivery of high quality and high value care, three groups of individuals' parts come together and view the issue in different angles. The patient family perspective, the healthcare professional perspective, and the system representative perspective. The individual parts include primary care, specialty care, inpatient care, mental health services, long term care, medical history, test results, home care, informal caregiving, patient and family education and support, medication and pharmacies, and community resources. It's easy to imagine if one cog of the wheel doesn't work, it can back everything up. Health literacy is the degree to which individuals have the capacity to obtain, process, and understand basic health information and services needed to make appropriate health decisions. Does the patient have the mental constitution to make good health decisions for themselves? It's not always just on the patient to understand what's going on. The provider must also be able to clearly communicate the situation. Health literacy is a huge problem with patients. Only 12% of adults are considered proficient in health literacy, and 36% are below basic health literacy. One of the issues with explaining polysomnography with patients is just how complicated everything can be. There are millions of numbers to think about with polysomnographic data. AHI, TST, sleep percentage, time in bed. Providers and educators must be able to break it down and translate the data into plain language. This involves organizing information so that the most important information comes first. Break down the complex information into smaller, understandable chunks, and you can even leave a lot of white space on the pages and make it a little easier to read. Appearances can be intimidating. If you've got just a sheet that's filled with stuff, it's overwhelming. One of the best ways to know if you in fact know something is to try and teach it to someone else. It forces you to think outside of the box and explain things in a way that makes sense to your brain and then make that make sense to someone else. This is called the show me method and ensures that the patient understands by teaching you what they heard you say. Uh, Try not to use big words like reticular formation or other medical jargon unless it's something like hypopnea, which is necessary. It's a word that we need to use. It is on the sleep technologist to make sure that they are effective communicators. When the patient has finished testing and they and their providers have chosen a suitable treatment plan, the goal is to help patients outside of healthcare bubble and thrive on their own. The goal is to help patients along their therapeutic journey to achieve successful outcomes uh, by improving their quality of life and reducing the burden of illness and achieving control of their condition. We reach our goals with improved adherence to personal lifestyle modifications, treatment regimens, and routine follow up care to make sure everything is progressing as the plan intends. There are a few effective ways to improve long term adherence to therapy, including behavioral intervention. If you witness or having witnessed evidence a patient is doing something adverse to their treatment and effectively changing that behavior. Further education and care coordination with the various facets of holistic healthcare. Alone, the patient's education is just not enough and has not been shown to make a difference. But when the patient is engaged and active in the process, education is more successful. Engagement is action that individuals must take to obtain the greatest benefit from their healthcare services available. Activation, which is a component of engagement, is understanding one's role in the care process and having the knowledge, skill, and confidence to manage one's health and healthcare. Engagement is the light switch, and activation is the light turning on. It's important that the patient possesses the knowledge and skills to care for themselves by knowing the condition and how to take care of their medical equipment. One person that may get left behind is the bed partner, especially in sleep medicine. When the bed partner is involved in the process, though, PAP usage is enhanced. They are often forgotten, but they themselves may be suffering sleepless nights secondary to their bed partner's sleep issues. Patients can lose motivation to continue treatment if they lose sight of the big picture. Motivational enhancement is a client-centered directive method for enhancing intrinsic, internal, motivation to change by exploring and resolving ambivalence. Ambivalence is having mixed feelings or contradictory ideas about something or someone. Uh, Sometimes when I'm with my 4-year-old for 5, 6, 7 hours on end, I'm like, can I just get 5 minutes alone? And then when I am alone, I'm like, I miss my baby and I want to go back. Ambivalence. In order to change this behavior, we have to ask open-ended questions, which gets more than a yes or no answer. Why don't you use your CPAP anymore? You have to give a reason. You can't just say yes or no. Do you still feel rested without CPAP? How does your spouse feel about that? We engage in assessment of change talk, which means we try to judge how much a person really wants to change through analyzing the intent of their words. And we could also create a discrepancy. I prefer illuminate a discrepancy because the discrepancy is already there and the patient just might not be aware of it. This one should be probably used sparingly in these times. It's not considered very kind to be as direct as, well, if you don't use your CPAP, which is causing your hypertension to be out of control, you're going to die. I personally leave this language up to the physicians. Creating discrepancy motivates change by causing the internal struggle between the present behavior and achieving personal goals and keeping true to their values. I have a intrinsic motivation to be a basketball player, but I'm also spending too much time on the couch. I have an internal conflict because I want to be good at basketball, but all I do is sit on the couch, and that's not really good for basketball. That makes me boil inside. That's a discrepancy and an internal conflict. Here's some examples of change talk, how to elicit change talk, and examples of what patients might respond to. If you want to, you can pause this and check it out. These are just some examples. To make sure that you, as sleep technologists, provide the best care for your patients and educate them appropriately, it's mandatory to accrue continuing education units or credits to maintain your certification. You've heard of them as CECs or CEUs, which you can get through your ISRs. Unfortunately, the amount that you can claim this year is it's being reduced, but you can get them at conventions, conferences, and online classes. You must remain up to date, an up to date resource for your patients. It's your responsibility to seek out and review the latest literature and have a thorough understanding of the various therapies available and knowledge of new technologies and how they can shape the future. And a lot of this is lab centric. They will be a good lab is subscribed to magazines and literature or uh, a peer reviewed website that gives you this literature so that you don't actually have to go and look for it. But all that stuff is out there, and you can find good information if you know how to look for it. All right. Well done, everyone. We'll get back on it next time. Study hard, and if you need anything, you know where I'm at.